Hi, everyone. Yes. Okay. I'm Sebastian Dewhirst. I'm here from Ottawa, Canada, and I'm going to be presenting our work developing and then evaluating a novel assessment tool for assessing emergency medicine residents' readiness for independent practice. I'd like to thank our co-investigators, as well as University of Ottawa's Department of Innovation and Medical Education, who provided grant funding for this project, and I have no conflicts to declare. In Canada, emergency medicine programs nationally adopted competency-based medical education program this past year, and workplace-based assessments are going to form the cornerstone of assessment within any CBME system. CBME is also an outcomes-based approach to education, and for a emergency medicine residency program, the most important outcome probably is to graduate residents who can independently run a shift. I mean, it's not the only outcome, but it's probably a key one. Currently, daily encounter cards are the most commonly used form of work-based assessment in emergency medicine. They have several benefits. First, they evaluate a resident's performance over the entire shift. Secondly, they minimize recall bias because they're completed right at the end of the shift. And they also provide an opportunity to provide feedback to the resident right after the shift. However, like most other forms of workplace-based assessment, daily encounter cards have several limitations, including leniency bias, range restriction, and an inability to discriminate between residents of different abilities. Entrustability scales are scales where the anchors are tied to the amount of direct supervision a resident requires to safely practice medicine in whatever field you're in. And that aligns better with how faculty naturally supervise learners compared to comparing a resident to an expected level of ability, which can be kind of a nebulous concept. Entrustability scales have been shown to be easily understood by faculty and residents and have decreased leniency bias and range restriction issues in some settings. So we sought to develop a new assessment tool that would assess a resident's readiness to independently run an emergency department shift. We wanted the tool to be reliable, to be able to differentiate between learners of differing abilities, and to be easily understood by faculty and residents. So first, to develop the items for the tool, we held focus groups with faculty in our local center, and we asked them the question, what skills and attributes are required to run an emergency department shift? We then had a group consensus method with several rounds of generating and then voting on items, where consensus was defined as 80% agreement. And then once the items had reached consensus, they were emailed to prominent educators in emergency medicine throughout Canada for more feedback on the items. Then we used those items to populate our assessment tool and tied them to the entrustability scale, which is shown at the top of the screen and ranges from I had to do to I did not need to be there. And then at the end of the item in blue, like the number 1, is just one of the items on the tool. I think, if I remember correctly, there's 14. And then at the end, the faculty are asked whether or not the resident could have performed independently on that shift or not. So we instituted this new tool in June of 2018 and collected data for 6 months, which was just over 1,100 completed assessment forms. And this chart shows the distribution by level of training. And then we ran a generalizability study, which allows you to assess which factors are contributing to overall variability in the scores and what the relative contributions are. So training level, or PGY year, shown in orange, was the most important contributor to overall variability. The gray wedge at the top was the variability caused by different residents within a PGY year. That was about 5%. And then the blue wedge is the the day-to-day or shift-to-shift variability within a specific resident. Generalizability studies can also let you assess the reliability of a tool. So we found that our tool could reliably estimate a resident's competence or ability to run the shift after about 33 assessments, which is a fairly high number, but also is reached in 2 months of emergency shift. So it's not such a long period of time. So on this graph, each bar represents a different resident. The orange diamonds or circles are the mean overall score for that resident over the study period. And then the gray bars represent the maximum and minimum scores they received on an assessment form over that period. So we can see a couple things from this form. First, mean scores increase with increasing level of training, which is what we want. Secondly, the total variability in scores, or like the height of those bars, decreases with increasing level of training. So as they become more senior, they're more reliably good, or perform more reliably well, I should say. And then we also see that just overall, there's a big range in total scores that were awarded to the residents, showing that the faculty are using all or most of the scale and not just like the right half. This graph has quite a bit going on. So we have two different series. In blue, we see the mean scores for those forms where the faculty said this resident could have been independent on this day or on this shift. And then in orange, we have the mean scores for the forms where the faculty said they could not have been independent on that shift, and stratified by PGY year. And the size of the bubble shows the number of forms that fall in that category. So we see that as we move from PGY1 to PGY5, more and more residents are being told more and more often that you could have been independent today, which is what we would hope would happen. We also see that if you look only at the times where they were not deemed independent, the scores correlate with level of training. But if you look at the times where they were deemed independent, there's no correlation between the mean scores on those forms and the level of training. Contrasting these two trends would indicate that the numeric scores of the form correlates well or predicts when the faculty overall feels that the resident could be independent. So in the third phase, we got feedback on the form by focus groups and a survey. And faculty and residents both said that the form was easy to use, that it generated useful feedback, and that residents were accepting of receiving lower scores, which was not previously the case. So in conclusion, we developed a novel assessment tool that assesses a resident's readiness to run independently run an emergency department shift. We found it to be reliable after about 2 months worth of assessments. It differentiates between learners of differing abilities. It's easily understood by faculty and residents, and it generates useful feedback for the residents, specifically about how they can become more independent in the future. Thanks for your time, and I'll take any questions. Yeah. Sure. So the question is, was it collected electronically or by paper? And so we use 145, which is like an online electronic assessment. So the form is accessed online and filled out electronically and then saved in an online database.
Was the feedback anonymously or with the resident there when you're filling it out together?
So the question is the feedback given anonymously or with the resident? So the form should be completed with the resident. That's the ideal. Sometimes it's not, but informally polling faculty, it's about 90% of the time that they finish it on shift. And there's written comments that we don't analyze in this study, but the written comments are really like the highlights of the discussion that you had with the resident on how they could be more independent and what they need to do differently to get there.
We've done some generalizability studies with student assessments.
Yes.
We found that 60% of the variance is due to the faculty.
Mm-hmm.
But I didn't see faculty as listed.
Yeah, so the question is, in other generalizability studies, the faculty play a major role in variability, and here it's not listed. So the reason we couldn't do faculty is because, or the reason we didn't do faculty, is that not all faculty assess all residents, and the cases are different each time. So Again, I'm not the main analyst, but my understanding is that because not all the faculty are paired with all the residents, you couldn't nest it in such a way as to pull out the faculty-specific data. But the faculty variability would show up. Sorry, I don't know why it's so many slides. It's not actually in this random, well, not the random error. It would show up in the assessment part, because that's part of why there's variability between shifts. A lot of that variability is not like the resident on one day did super well and on the next day did really poorly. It's just one day they worked with a staff who marks harder, and one day they work with a more lenient staff. Probably that's contributing to a lot of that, but we couldn't tease that out directly.
You may want to go back to the stats people, because apparently there's different methods of running machine and unbalanced.
Okay, I will talk to them. I know. So I know a follow-up study on this is looking at assessor leniency and stringency specifically from the same data. Yeah, but it's not in this one.
Where did you physically do it? Because in my mind I'm thinking about our shop, where it's difficult to have a space where you and the resident can talk privately,
Yeah.
give them feedback, mid-possible.
Yeah, so the question is, where did we physically do it? That's a good question. We just have suboptimal feedback situations. So it's just done at the same desk where you ran the whole shift. And there's other residents about. If you had sensitive feedback, you would usually pull the resident away to a faculty office. But this same system of giving feedback at the end of the shift has been our norm, our practice for like over a decade now. So at least among the emergency residents, it's just felt as normal that you're just giving feedback in a somewhat public environment. But it's not optimal. Yeah. Thank you. Great. Thank you.